Nykanen. I'm a fourth-year medical student at Florida State, and the co-author and my mentor for this presentation is Dr. Barr from Radiology Associates of Florida. Today's presentation is preoperative evaluation of anorectal malformations using augmented-pressure distal colostogram. So the disease process is also called anal atresia. It affects about 1 out of every 5,000 births. It affects males more than females. The cause is likely due to incomplete hindgut development during embryogenesis, resulting in a presentation of absent anal opening and an eventual failure to pass meconium and abdominal distension. So treatment is a two-part process. Both of them are surgery. The first one, long name, but it's kind of simple idea. You divide the colon into a proximal and distal segment, and then pull the opening from each through the abdominal wall. So the proximal segment will be the diverting colostomy portion, and then the distal segment will be the mucus fistula connection. This is just temporary until about 4 to 6 weeks after birth, give enough time for the baby to stabilize for a more extensive surgery, which is the posterior sagittal anorectoplasty, which is just the posterior approach to this repair. And this could be with or without laparoscopy, which is the anterior approach. So factors that will change the idea of how we approach surgery depend on two main ideas: the anatomy of the rectal pouch, and then the presence of any fistulas, which is present in 95% of cases. So most likely will be there, and can be anywhere from the bladder to the urethra and the overlying skin. The difficulty with evaluating these two factors here comes with the surrounding musculature from the pelvic floor that is collapsing any fistulas that are present, and the rectal pouch. So MRI is really not sufficient for evaluation. So we needed to introduce hydrostatic pressure into the distal colon using augmented pressure distal colostogram, which is currently the gold standard for evaluation. And we'll show you a case here. So on the left image, we have a lateral radiograph. Well, it's a fluoro image from a fluoroscopy during the colostogram here. We'll start off with placing a marker where we believe the opening of the anus should be. So you can see that on the bottom. And then starting from the top there, you insert the balloon catheter into the distal colon through the mucus fistula. Insufflate the balloon and then retract it to the abdominal wall so that we form a seal, and then inject the distal colon with contrast. So the combination of the contrast and the seal from the balloon is the augmented pressure of this portion of this procedure. And then on the very bottom, you can see a streak of contrast starting from the inferior aspect of the rectal pouch and then extending all the way to the positive arrow sign there, which is indicative of fistula. And then you can see extravasation of the contrast outside of the actual baby. So based off the image alone, without having the image on the right, which is the intraoperative photo, we can safely assume that there's a fistula that's going either to the urethra or the overlying skin. And so during the actual operation, when the distal colon was filled with saline, you could actually see some of the saline coming out of a small opening at the base of the penis. That's what's kind of lifted up at the top of the image. So it confirms a rectoperineal fistula. And then this is an AP view image taken by fluoroscopy, also from the same colostogram, that helps characterize the shape and of the distal colon and the fistula itself there. All right, so this is how we put this image into words here. That's useful diagnostic information. So if you draw a pubococcygeal line, which starts from the sacral tip and goes to the femoral head, that is kind of a reference line that we use to determine the approach to surgery about that when we're talking about the anatomy of the distal colon. So if the distal colon extends below that pubococcygeal line, then it's safe to just assume that we're going to use the posterior approach only. And if it's above or superior to that reference line, then this will likely require a combined approach of posterior and anterior surgery. And then on the right, you can see help further characterize it's 2 centimeters from the actual opening. Or not the projected opening where we want it to be open. So the final diagnosis, like this, really is just like, we knew it was already there at presentation, but now we get to fully characterize it using the distal colostogram. So on the left, we know that it's inferior to the pubococcygeal line. And on the right, we can see that a fistula is present. So that gives us a more complete diagnosis. So anal atresia that is below the pubococcygeal line, and it has a rectal perineal fistula. And then management, this is a lot of what I've already discussed here, but the only other thing is that for this case, posterior sagittal anorectoplasty was sufficient alone, even when you consider the fistula, because the only time they would need to use the anterior approach is if the fistula goes to the bladder. And in this case, it did not. And also management requires looking to other congenital malformations like Bacterial syndrome. The outcome is generally pretty good. Colostomy can be closed after 6 to 12 months, depending on how well the baby's healing. And then long-term consequences may be constipation or some incontinence, but generally pretty good lifestyle. And then if there's any other congenital malformations, it might require lifetime follow-up. So the key takeaways here is that the relationship between the pediatric surgeon and the radiologist was crucial for this case and for this patient. The rectal pouch is collapsed from musculature, so it requires hydrostatic pressure in order to expand it and fully visualize it. And that's where augmented pressure distal colostogram comes in. That's the gold standard currently. And then technique is really important for this procedure, but can be difficult because you're dealing with a newborn baby who probably doesn't want to sit still while this is all going on. So if you would like to learn more, here are my citations. And what questions do you have?
What happened to the rectal perineal fistula? You guys have to do anything about it?
So that's taken down during the surgery. Yeah. But what's the good news is that the surgeon already knows that it's there instead of having to check and make sure that one's there. But simple takedown. Any other questions?
I missed the first. Sorry. Were there any other obvious factoral deformities or anything else?
For this patient, there was no Bacterial syndrome or other congenital malformations. It was simply the anal atresia by itself.
That really helps.
I don't think so, not for this case. That's Dr. Barr, my mentor. Any other questions? All right, well, thank you all for having me, and thank you, Dr. Barr, for being my mentor.